welcome everybody.
Yep.
Press this, light goes green, it means you're good to go.
research fellow for 2 years. She was a research fellow at Academy of Education, Academy of Harvard Medical School. She was a Rapkin Fellow in medical education at Carl Shapiro Institute for Education and Research at Boston, Israel. She held several leadership positions over the years, a lot of them with the American Thoracic Society. And she is somewhere at the root of some of the mock questions that we have to answer. In 2019, she began thinking about a center for humanizing the ICU, picking up on understanding that the care of our patients is not just medical, but has to be as a whole person. And in 2022, she became the founder and co-director of the Center for Humanizing the ICU at Beth Israel Deaconess. She also is co-chair, or was co-chair of postgraduate courses at ATS. She's a member of many professional societies. And in her own words, her true passion is to care for critically ill patients, to develop tools and systems for their care, and provide education for those who care for these patients. Areas of interest are improving the experience of dying in the ICU, develop standardized tools and curricula to improve communication in the ICU. She wrote perspectives, research articles, gave local, regional, and national talks on communication in the ICU. In addition, she is interested in how we teach and to change the paradigm and the focus from memorizing facts to critical thinking about problems. So she teaches critical thinking to learners at all levels, locally and nationally. And after this talk here, she will have a roundtable with our fellows, topic being critical thinking in the ICU. Okay, so who would like to join, they're welcome. She's very active nationally and internationally, teaching critical thinking and communication. And recently, she was appointed as the deputy editor to Chest Critical Care Medical Journal. So I won't take any more time. So please join me to welcome Dr. Hayes.
Thank you. Thank you so much for that wonderful introduction, and thank you all for the honor to be here. Just get the slides up. Okay, this looks good. All right. So as you heard, can I just X these out? Thank you. Thank you. So as you heard, I'm really excited to talk to you all today about humanizing the ICU. I have no disclosures. I have two disclaimers, though. One is that I'm not here to tell you that I have a human ICU and you do not. This is a passion of mine and something that I struggle with and that we struggle with at Beth Israel, and I think we struggle with in critical care and in medicine in general. So I'm really going to share a lot of the challenges that I've had and hopefully give some tips along the way. And I'd love to hear what you all do and love to hear your tips and tricks. The other disclaimer is that I know not everyone in here works in the ICU or primarily works in an ICU. So think about some of these humanizing characteristics and tips that I'm going to present and how you can bring them to wherever you work. If it's in the ambulatory setting, on the wards, in a procedural area. So don't feel like this doesn't apply to me because I don't really work in the ICU. Think about how you might really take what I'm saying and apply it to the location and the context that you're in. So the objectives for the next hour or so are to define human-centered care, identify humanizing and dehumanizing aspects of critical care, and describe a framework for providing human-centered care. So whenever I talk about this, I love to start with this quote: "In the sufferer, let me see only the human being." And I think in medicine, we've often gone away from this, and it's nice to remind ourselves of this. In the sufferer, let me see only the human being. And I want to start with the case. This is a Grand Rounds presentation, of course, so we have to start with the case. But unlike most Grand Rounds that you have been at, this is actually not a patient case, but a doctor case. So Dr. X is a 32-year-old male trainee rotating in the ICU. He is caring for Miss A, who is a 90-year-old female with hypertension, COPD on 3 liters of home oxygen, heart failure with an EF of 30%, and dementia, hospitalized now for 22 days, including 2 ICU admissions, who's back in the ICU with hypoxic respiratory failure requiring non-invasive ventilation. Dr. X updates Miss A's daughter and informs her that her mother is quote-unquote very sick and may need the breathing tube. Miss A says, "Do whatever it takes, doctor." Dr. X knows that he should talk about end-of-life care, but he doesn't want to bring it up since the daughter didn't. He doesn't feel comfortable broaching the subject, and he has no time since there are 4 admissions and 2 procedures waiting for him. Does this sound familiar? People can relate? So this was a real case at Beth Israel Deaconess Medical Center, and Miss A was a real patient who unfortunately died in our ICU. And Miss A's daughter wrote this on her FSICU, Family Satisfaction in the ICU survey. Everyone kept saying that mom was really sick. I wish I knew that really sick meant dying, because then I could have been there. And as a new MICU director, this quote came across my desk, and I felt awful. I feel like I get a little choked up every time I talk about this. I felt like we failed Miss A, Miss A's daughter, and Dr. X. So I thought, what can we do? How can we make this better? This was a failure for Miss A and her daughter. But also, Dr. X received that feedback from Miss A's daughter, and the combination of her words, his belief that he had made a mistake, and a busy 4-week ICU rotation crushed him. So we failed him too. So how can we do better? And was this human-centered care for the patient, for the family, for the provider? And I'd argue that no, it's not. But let's sort of dive into what is human-centered care. So the Center for Medicare and Medicaid defines human-centered care as integrated healthcare services delivered in a setting and manner that is responsive to the individual and their goals, values, and preferences in a system that empowers patients and providers to make effective care plans together. To me, this is one of those very hand-wavy definitions. I hate on rounds when we talk about hand-wavy things. I'm like, but what does that actually mean? So that's really the question. What does this mean? This sounds great, but how can we do this? And when we started out creating the center, that's really what we wanted to do. How can we practically do this? How can we do this as busy physicians? We know that in medicine, and very particularly in the ICU, a lot of what we do just by the nature of critical care is dehumanizing. So just comparing and contrasting, humanization is honoring the complete identity and dignity of another, whereas dehumanization is viewing or treating another as less than human. And oftentimes we do this inadvertently, again, just by the nature of critical care. There are many things in the ICU that we do that cause discomfort to the patient, to the family, and the provider. This is a nice study from 2022 looking at all of these discomforts. And you can see everything listed here: hunger, sleep deprivation, lines, tubes, cables, shortness of breath. We're not willingly doing these to the patients, but all of this happens because of being in the ICU and because of the care that we provide. And it causes harm, and it's dehumanizing to the patient, to the family, and to the provider. So the good news is, though, that a list of humanizing behaviors, which is here on this green box, is much longer than the dehumanizing behaviors or the dehumanizing characteristics that occur in the ICU. And we can do this. We can work together to humanize the care in the ICU and humanize the care everywhere in healthcare. This is a framework from the International Research Project for the Humanization of the Intensive Care Unit and the Humanization of Healthcare that shows these 8 sort of characteristics or structural changes, I like to call them, that you can do in your ICU to make your ICU a human ICU. And we're going to talk about each of these. Some I'm going to go into more depth than others. But each of these, I think, are important and crucial. And as we go through them, I want you to think about, am I doing that in the place where I practice? And if not, how can I? Or what can I do to make a change? And I also want you to keep in mind that as we talk about this, I really want you to think about it in the context of the patient, the family, and the provider. We want to humanize the experience for everyone, not just for the patients. So I'm going to lump two of these together to start out. So open ICU visiting policies and the presence of relatives. So in 2014, there was this nice commentary from Don Berwick in JAMA saying that we need to open up the ICU and have unrestricted visiting hours. And I was really proud when I joined BIDMC that we had that. People could come and go pretty freely as they pleased. Of course, calling and making sure they could come in, that they could stay all hours of the day. We had sleep rooms at night. We had families on rounds. And then COVID happened, and everything shut down as we had to. And we're not back to that level pre-COVID. What about here? Are you open totally? People can come and go as they please? No. So we have visiting hours. You have visiting hours too? Yes. We have the same. So we have 11 to 8. We make a lot of exceptions in the ICU. But this is a huge problem and a huge challenge. And we've been pushing nearly every day. I think hospital administration is getting annoyed with me for continuing to say we need to open this up. But this is so important. Tons of data in the ICU world. So this is the A to F bundle from the Society of Critical Care Medicine, really highlighting the importance. The F piece of this is family engagement, of families being involved, being present, being on rounds, helping with therapy. Really important to improve the care of patients. Really important to decrease delirium. Overwhelming amount of literature showing when you use the whole bundle, the A to F, there's decreased ICU length of stay, decreased hospital days, decreased delirium. But it's a huge problem that we're not able to open back up yet. In 2017, these recommendations were published saying that family members should be there. They're a crucial part of the team. And now it's almost 2025, and many hospitals, mine included, we're not there. We don't have this. So this is a problem that we all need to work together to really try to fix. Some mitigating strategies that we use is we'll allow families on rounds via speakerphone. As I mentioned, we made a lot of exceptions. We'll let people come, beyond the visiting hours. But it creates a challenge. If I, as the MICU director, allow that, then someone goes to the floor and they have different rules, and that's dehumanizing as well. So it's a huge problem that we're continuing to work on. But I think one of the main things that we can do to really humanize the experience. The next piece of this framework is communication. So in the ICU, there has been a history of poor communication. 30% of ICU families are unhappy with communication. 50% do not understand the diagnosis or prognosis. And in audio recorded family meetings, physicians spoke 75% of the time. 75% of the time. That leaves no opportunity for the families to be able to respond or express emotion or to have a conversation. It was like the physicians were just giving a lecture. So how can we do better? We have to do better. In 2015, this multi-society guideline was published, really looking at how to respond to requests for potentially inappropriate treatments and how to resolve conflict in the ICU. But the authors and the committee that wrote these guidelines said that we need communication skills training for all. So quick show of hands, who's had dedicated communication skills training on how to have a family meeting? So it's not as much as you'd think, right? Every time I do this talk, I feel like there's more and more hands, but I didn't when I was in medical school or in residency. This is something we're doing more and more now, but it's a problem. We need to teach people how to communicate. We need to teach people how to have these meetings. The committee also said that we need supervision and observation for family meetings, that we should capitalize on communication expertise from social work, palliative care, and spiritual care, and there should be a protocol for communication challenges and disagreements. So at BIDMC, we actually have a structured curriculum for our interns when they rotate through the ICU. So 1 hour a week, they're pulled from the ICU. And we have dedicated communication faculty, and they do a lot of role playing. We actually use family member volunteers. So if you want to volunteer at the hospital, you go to the volunteer office and you could say, hey, I want to be one of these communication volunteers. They're trained on the case and trained how to give feedback. And, we teach them some of these main skills that I have listed on the slide here. But one of the biggest things is, treating patients as people. And then some communication techniques, ask, tell, ask, using simple language, responding to emotion before cognition, and appropriate word choice, and running family meetings. This curriculum was actually studied before I joined BIDMC. This is work from Amy Sullivan and Laura Rock. And they actually showed that residents who participated in 2 to 3 of the course sessions were more likely to meet the needs, the emotional needs of the family. The families were sort of given surveys immediately after family meetings to rate the residents of whether they met their emotional needs or not. So the training was really helpful and really powerful, and something we continue now. We've morphed it a little bit, and we've also added on or layered in sort of advanced communication training sessions for our residents. So the intern course really focuses on a lot of the basics, not using jargon, thinking about ask, tell, ask, and how you can use that communication skill. And then the resident courses, we really focus on how do you tell a family member that their loved one is dying? How do you manage conflict in family meetings? And how do you respond to miracle and God questions? And one of the things that we use when we teach this is this approach from the Lakin and Jacobson paper, this idea of balancing hope and worry. And we give the residents those tools, that language, like just literally say that. We need to balance our hope and our worry. So right up front, you're really letting the family know that we're worried. This may not go well, but we are not taking away that hope. We're balancing hope and worry. And every day can be a different day. Today we're more worried and less hopeful. Tomorrow, hopefully, we'll be more hopeful. But this is a great communication tool and something that we teach our residents. We also studied this at BIDMC. We're lucky we have 2 campuses across the street from each other, so we have 2 ICUs that, the same physicians, the same attendings rotate in, the same residents rotate in, the same respiratory therapists, but they're, separated by a lot of space, actually. So we're able to do a randomized trial. This was a fellow a resident at the time who's now an attending physician. And what we did was randomize residents either to receive a didactic on talking about death and dying with some skills practicing of literally just using those words, or do a simulated family meeting. So we were able to randomize them and then study this. And as you might imagine, no surprise here, when they did the simulation, they actually learned more new skills. This was their self-report, so it's a lower level education study, but it hadn't really been done before. And a lot of people say, well, we don't have time to do sims or family meetings when we're rotating. Busy residents. This is a huge problem in GME. How do we pull people out to really focus on some of these skills? We did this in 30 minutes before round started. We have a MICU communication curriculum, as I mentioned already, but we have every single day teaching 8 to 8:30. So this was just one of the teaching slots that we used. So it really wasn't a lot of effort. It wasn't a lot to pull them out, but the payoff, I think, was worth it. The reward was really high for this. This is something we think a lot about and focus a lot about at BIDMC, and what we're trying to do is really change the culture and change our approach to communication. So one of my goals as MICU director is really to ensure that everyone thinks and knows that having a family meeting is just as important as placing a central line or as doing any procedure, that a family meeting is a procedure. And there's 3 things we're trying to do. We're trying to standardize the communication, make sure that we have family meetings within 24 hours, make sure they're documented. And I'm saying make sure because this is all pie in the sky ideas. I feel like all my faculty are tired of me talking about this, but it's so important. And even when I try to search the record, like how we document family meetings is so different. Some people will put it at the end of their attending notes. Some other people write their own notes. So we're working hard to really structure and formalize how we document this. We just switched over to Epic in June, which is helping us now to really finally be able to structure this a little bit more. We have the resident training, as I mentioned already, but one thing that's lacking is supervision. So it's pretty common, I think a common experience in all ICUs, where a patient comes up and is critically ill, maybe peri-arresting, and everyone is in the room. And who do we send? The intern. Oh, go update the family. The person who has the least experience, who maybe has never done this. We don't leave them in the room to place the central line. Why? Right? Because we think about these 2 things differently, and I would argue and advocate that they should be thought of as equal, and you should send someone with the intern. This allows support for the intern, but also allows someone to be able to observe and give feedback, or for them to do it together and have the intern actually watch someone do this. So we're really working hard to change this, and I completely get it. Sometimes it's not possible in the ICU. So that's our hope, is that we train all the interns and give them some of these skills and empower them to be able to do this. Then we're doing a lot of faculty development. So we have a core communication faculty, and we try to keep bringing new people into that fold, because just by teaching this, you get better at doing it yourself. So we're working on these three things. And I will say it is a work in progress for sure. Our documentation has gotten better thanks to Epic, and we're doing a lot better with our resident sort of supervision. And we now have feedback forms for our fellows. When our fellows are doing family meetings, we'll fill out a form immediately after and be able to go over the feedback with them right away, and then also give the forms to their program director, which has been working well. So the next piece of this sort of framework is end-of-life care. And this is a big passion of mine, and how I sort of got interested in this was really trying to improve the care of the dying patient in the ICU. So I know I'm preaching to the choir here when I tell you that 1 out of 5 Americans die in an ICU, and 30% of Medicare beneficiaries receive ICU care in their last 30 days. 58% of in-hospital deaths include an ICU stay. So as an ICU doctor, we have to know how to practice end-of-life care. We have to be good at this, because a lot of our patients are dying. So we have to know how to do this. In 2015, the Institute of Medicine put out their Dying in America report, so almost 10 years ago now. And they said in this that improved care for people near the end of life is a goal within the nation's reach. It is a matter of professional commitment and responsibility. Almost 10 years ago, and I'd argue that we're still not there yet. And the 2014 Choosing Wisely campaign for critical care, their last number 5 on this list was, don't continue life support for patients at high risk for death or severely impaired functional recovery without offering patients and their families the alternative of care focused entirely on comfort. We don't do this. And these are old sort of recommendations 10 years ago. We still struggle with this everywhere across the country. Why? Why is that? Well, it's been shown that there are a lot of barriers to end of life, to talking about end of life, to providing effective end of life care. There are 4 main ones that are in the literature. The first is the reluctance of patients, families, and physicians to explore death and end of life issues. It's a cultural thing. No one wants to talk about this, right? Even the words we use to our friends and family, we soften a lot. I was listening to a podcast recently, and the person was saying, when we talk to our friends, we say, I'm so sorry you lost your father. And he said, I didn't lose him. I know where he is. It's like you lose your car keys. You don't lose a loved one. But these are the words that we say in America. We struggle with this. And then this leads to challenges in healthcare, because we struggle talking about death and dying. We also have a fragmented healthcare system. People in my unit bounce back and forth, unit, floor, rehab, ED, floor, unit, back and forth, and we often feel like, oh, someone else will take care of this, or this will, is someone else's problem, or they're going to see their primary care, or they're going to see their oncologist. This is a challenge in American healthcare, that it's pretty fragmented. There's poor quality communication. I already showed you some of the data for that. And then there's inadequate structural support and a lack of training. You saw the number of hands that went up when we said who had communication skills training. This is a problem. And there's also not a lot of support for the teachers who are doing this work. So these are the 4 main barriers. Jessica Zitter wrote in 2014 this Code Death for Dying Patients, which is an old paper now, but still one of my favorites, because I love this line from her that she says, we physicians need to learn the ancient art of dying. It's so important and something that we don't think enough about. We physicians need to learn the ancient art of dying. And she says in order to do this, you need 2 things. 1, the recognition that it's time to shift, or knowing when to offer care focused solely on comfort, and then the technical skills to help someone die well. So when we think about recognition of the acutely dying patient, it feels like this should be easy, right? We should know who's dying. Well, it's not. Jack Awashina from Michigan, who's now at Hopkins, wrote this paper in the Annals of the ATS of how to recognize a patient who's acutely dying. And I want to point out he has this table of concerns here, this last concern of who's experienced enough to do this. And he says he thinks the task should be done by the attending physician with input from all team members. And I agree with this. I think it's something we don't talk enough about on rounds and something that we should really talk about. And when we leave this to our trainees, we're setting them up for failure, and it's not sort of human care for them because they're not equipped to do this. We actually did a qualitative study. This is Christine Beltran, one of my former research assistants, where we tried to really unpack of, why do residents specifically, so internal medicine residents, why do they struggle talking about death and dying? So we had them do family meetings, and we coached them. We said, this was a time-limited trial. This person's getting way worse. Your job is to, and it was all written out in the clinical information, your job is to tell the loved one that, the daughter is dying. And only one group did it, despite us saying, use these words, say this. Only one group did it. And we did a lot of qualitative analysis to really sort of unpack why is that? Why do residents particularly struggle with this? And came up with two challenges. One was discomfort with patient prognosis. It was a real challenge for residents to say, hey, I don't know if this person's going to live or die. I don't want to just say that. And the other challenge was the fear of families' reaction. So this is a challenge that we need to help our residents through. And in one of these family meetings, we had sort of an actor, playing the aunt of the patient who really, got tearful. She was banging her head on the desk. And after, when we paused and debriefed it, I said, how'd it go? And the resident who was leading it said, terrible. Look what I made her do. And so just changing the way we think about that, yeah, that's awful and uncomfortable to have someone cry and to feel like you made someone cry. But you didn't make her do that. Her niece is dying. That's why she's crying. So we need to support our trainees and help them realize this, help them be in that emotional space. Because what we found in this study, that these challenges lead to a softening of the dying message, leads to the mom's really sick. And people don't get that message that their loved one is dying. So there's a lot of work to be done in this space for all of us, but especially for our trainees, I think. So we need to really explicitly recognize the emotional challenges and the burdens that we all feel when talking about death and dying, but particularly our trainees. And you can do that with good pre-briefs and good debriefs. We talk a lot about how to respond to emotion, how to name the emotion and recognize the emotion. We talk a lot about silence. And I wrote this blog a few years ago about just sitting with suffering, just sitting in silence, and how uncomfortable it can be, but how powerful it can be. And this is a skill that's not taught, and something that I personally think we really need to be teaching people. I also think reframing is really important. A lot of my friends who are not in medicine are like, why do you like to talk about death so much? And why do you like to do this? I feel like it's such an important part of our job. So Dr. Herx, the president of the Canadian Society of Palliative Care Physicians, said if physicians can grow their capacity to have these conversations, they will increase their feeling of connection with some of the people they're serving. It will ultimately help their jobs be more rewarding and more meaningful for them. This is how we take care of our providers and how we humanize the experience for them. Give them the skills and the tools, help them find meaning in the work. And for me, helping someone die well is just as important as helping someone live. And reframing that part of our job, I think, really helps to have joy in the work that we do. And then when we think about the technical skills to help someone die well, I think checklists and order sets are really important. This is a picture of one of our comfort-focused end-of-life care checklists. When I was a fellow at Hopkins, I did a lot of this work as well. And when you dig into this, you realize that a lot of mistakes are made. People are extubated while still on a paralytic. People are extubated without appropriate sedation. So really highlighting the importance of this, using a checklist, using a pause, using a timeout, and really highlighting to the whole ICU team that helping this person die well is just as important as taking care of this patient next door with shock and ARDS, or thinking about ECMO for the patient 2 doors down. This is just as important. And really changing the culture and changing the way we think about it is a way to improve that. So when we think about end-of-life care and how we can improve it, we need to recognize when someone is acutely dying. We need the technical skills, communication. Checklists, I think, are helpful. And then something that I think is really valuable is marking death with dignity. So the 3 Wishes Project is a way to do that. This was created 11 years ago by Deb Cook in Canada. And it's a way to give families sort of meaningful memories or small keepsakes at the end of life. It's really populated here in the U.S. by Tom Neville at UCLA, who has done a ton of work on this. She is probably the most prolific sort of researcher on this. I'm showing you just 2 papers right here to highlight a few things. One is that the cost per patient in this 3 Wishes project was a little more than $5, but almost 450 wishes, so 430 wishes incurred no cost at all. And then another paper showing that, when you do this 3 Wishes program, you improve emotional and spiritual support. So a powerful thing to do. We at BIDMC are formally part of 3 Wishes. We've been doing this for a little over 2 years. We've enrolled 225 patients and families. You see some of the demographic data here. And then I wanted to just show you some of the keepsakes. So what we use, we have these glass bottles here that a volunteer actually makes for us with these little charms and these little forget-me-not flowers. And then when someone dies, our nurses will just cut out the rhythm strip, as you see here, and put it in these bottles and then give them to the loved ones as they're leaving. And we say this is a piece of their heart. People love this. When we first started this, I was a little bit concerned. I know a lot of this is done in pediatric ICUs. I wasn't sure how it was going to take off in an adult ICU, but people actually really love it and write us notes saying thank you for this, or come back and visit us and show us the bottles. We also do fingerprint keychains, so we can get fingerprints of the patient and then give keychains. This is really powerful for grandchildren. It was funny, when we first started doing this, some of the nurses were like, we don't have time to do this. How are we going to do this? And how many keychains are we going to give? How many are too many? And I was on in the ICU recently, and we had a daughter whose mother died, and she said, there are 20 grandchildren. Can we make 20 keychains? And I was like, oh gosh, these nurses are going to say no. But the nurses were like, absolutely. Like everyone's like bought in and really enjoyed doing this. We also have these heart keepsakes that you can see. So we give another little rhythm strip that we'll cut out and paste on a heart. We have a lot of data from our nurses about this, but I wanted to share this quote from one of our unit coordinators, because really once we started doing this, it took off organically, and everyone in the unit really helps out with this. But the unit coordinator said, to be able to offer a small source of comfort during a difficult time makes this program worth more than I could imagine. So it's just so important that everyone in the ICU feels like, they have a role and they're like doing a meaningful job and really impacting this family whose loved one just died. So it's easy to get involved and started in this. You can Google it, and Tan has created this whole sort of starter package, and you can use all of their branding for free. And again, it's pretty cheap to do this. Our cost per patient is a little over $2. We buy everything on Amazon in bulk. These glass bottles come like $15 for 100 of the glass bottles. So it's really easy to do this. Our Center for Humanizing the ICU, which is all philanthropy funded right now, pays for this. But before we had the center, when we started doing this, I would just pay for it out of the MICU budget, and it's really, really small money. But it's a big, powerful impact. So something I really encourage everyone to think about trying to do. So the last 3 pieces of this, I think, are all connected. And then we're going to talk about post-ICU care, too, which is part of this framework. The well-being of the patient and a humanized infrastructure, I think, go hand in hand. And I think when we have that, it's a way that we can care for providers. When we help our providers feel like they're doing a good job, they're really doing medicine for why they went into medicine. I hear so often, like, I'm just sitting at the computer, I'm just putting in orders, I'm just writing notes, I'm not connecting with the patient. That's why I wanted to do this. So when we do some of these humanizing interventions and when we have a humanized infrastructure, it really helps not only our patients and families, but also the providers. So I think it's important when we think about this to really go back to the platinum rule. So not the golden rule, but the platinum rule, which is doing unto patients as they would want done unto themselves. And how can we do that? Well, we really focus on treating patients and family as people, not as patients. We use ICU diaries. We focus on holistic spiritual care. We've worked hard to create quiet healing spaces, and we've created some welcoming waiting rooms and comfortable family spaces. And I'm going to share all of this with you of what we do at BIDMC. So get to know me boards are a way to really know who the patient is as a person. So this was published in Critical Care Explorations a few years ago. It's from the Mayo Clinic group. This is an example of we call it an All About Me board. So all of our ICU rooms have these All About Me posters. These are small, just 8 by 10, printed on cardstock. And what we'll do is when we get a new admission, this is with sort of the admission packet and paperwork, and whoever's doing the admission will start filling it out, and everyone will add to it. So our goal is to have it filled out within the first 12 hours of the admission. But asking the family, what does your loved one like to be called? Knowing what their language is so that we can be sure that we're getting a translator if they need one. Knowing if they use glasses, contacts, hearing aids, a walker cane. All these things help with delirium, but are so important to just humanize the patient. And then we ask them, what do you like to listen to for music? And we'll put that on in the room. What do you like to watch on TV? Many of the elderly patients just keep news on all day long. Or people want to listen to ESPN, even if they can't really watch it, they just want to have it on in the background. So we try to get a sense of what's your life like at home and how can we recreate that here in the ICU. So this is something that is pretty easy to do, but so nice. I love picking up a service and going in and seeing these all filled out and really learning about the patient as a person so that I can treat him or her as a person. ICU diaries, we started just exactly a year ago now, so just in January. This is a picture of our ICU diary. And it's just really a small notebook of blank pages. We have some instructions of what the diary is for. We also have some information about post-intensive care syndrome and sort of normalizing it, saying that, this is common, you might have it, here's how to get help, here's how to get in touch with our survivorship clinic. But the diary is a way for the patient, the family, and the providers to really make meaning of the ICU stay. So everyone's allowed to write in the diary. Our diaries, so when patients survive, they'll take the diary with them, and they'll often read it or process it in survivorship clinic and review it with one of the attendings in our post-ICU clinic. This is a nice way for people to understand what they went through. So, we had a patient who was having a lot of dreams. Our post-ICU doc, Kate Berg, who I'll talk a little bit about later, was telling us a lot about all these challenges that people have, all these bad dreams that people have. One of the patients that I saw was saying he felt like, he was in a war zone and heard bombs. And he had a diary, and you could go back and see, you were in the ICU on the 4th of July. There were fireworks going off. To be able to help him understand some of these memories and process it, they help him recover. So the literature and the research on this, I will be honest, is a little bit mixed. There is more out there. There are a couple trials ongoing now, and I do think it's going to be powerful. I just think it's a challenging intervention and hasn't been sort of widely utilized yet. But we do know that it decreases the risk of depression in patients and can preserve quality of life in patients. And we're still trying to understand how it affects the family and relatives, because if a patient dies, the diary will go with the family. And how does that affect them? Is it a positive effect? Is it a negative effect? Should we not be giving the diaries? So still work to be done on that. But this was an easy enough intervention, and we still struggle sometimes getting providers to write in it. Our nurses write in it. That's also well documented in the literature that the nurses are doing the majority of the writing. But our physical therapists will do this as well and say, you stood up today, you walked today, you went outside today. And it's nice to be able to have the patient have an account of their ICU stay that's not medical. You went to a CAT scan today, so we wheeled you down 3 floors and in an elevator. All those things are nice as people are processing and making memories. Another piece of this sort of well-being of the patient and the humanized infrastructure is the importance of chaplaincy or spiritual care. We are really lucky at BIDMC to have an embedded chaplain who is part of our ICU team. And Laura McNamara, who you see here, is one of our fellows now, thought this was so unique, and we wanted to sort of think about this a little bit more and write this up, sort of our framework. Because this chaplain is not someone we just call to say, the family wants a chaplain, can you come? But she's there. She's checking in with staff in the morning. How did the night go? What families need me? What staff needs me? So it's been really powerful to have this. And I know that we're lucky because it's not a funded position at many hospitals, but to have this embedded ICU chaplain, I think, is so important and so powerful. So I wanted to go back a little bit to talk again about some of these, remind you about a lot of these dehumanizing things that we do, because so much of the infrastructure leads to this discomfort. And the next few slides, I'm going to show you some small changes that we made to improve some of these discomforts. But really look at this long list: noise, too much light, uncomfortable bed, lack of sleep. And you might be saying all these things are like unfixable things. And many of them are. Many of them we can't totally fix, but I'd advocate that we can probably mitigate some of these. And noise was actually the first one that we tackled. So we got a lot of noise complaints in the ICU, especially at night. So what we did was a very small intervention. We bought these things on your screen here. These are called Yacker trackers. We got them from Amazon, and you can program them to a specific decibel level, and it will blink. So if you're over the decibel level that you want, so the World Health Organization says that we should probably be at 40 decibels. So we programmed it for a little higher, 45. So if you're over that, it'll start blinking. We also did passive education. So we talked about this at a few nurse staffing meetings and faculty meeting, but then we created this figure that you see here and just posted this all around the unit to kind of orient people to say, you know, a whisper is 40 decibels. And all of these things are over 40. And we're doing this all the time. And people just started to be aware of their behavior. So our units are really small. We have multiple small little 8-bed semicircle units. So if people are gathering, especially at night, right? People sit down, get out some snacks, and sit down and start talking. You quickly forget how your voices escalate. So it was just a nice, kind of quiet reminder of like, hey, you know, let's whisper. Let's go into the break room if we're going to have, you know, a party for someone or a celebration for someone, which we want to encourage. We want to keep doing those things. I'm not saying we can't have fun or we can't talk to our friends in the ICU, but we need to be mindful of these 8 patients who are trying to sleep, or we're hoping that they will sleep, and really be thoughtful about the noise. So this was a really minor intervention, and as someone who does a lot of education, I thought this will never work, this passive education, but we purposefully didn't want to tell people, you're being too loud, you need to stop, especially right now with all the challenges that we have in healthcare. We didn't want to sort of give them one more thing, like, you know, you're too loud, you need to lower your voice. So we just said, let's just try to roll this out. And people are really into it. And one of the Yacker trackers broke recently, and I was like, well, maybe we don't need it anymore. And they're like, no, we need it, we want it. And it's a nice reminder for us. So this is a small intervention that's really helped. We're thinking about ways that we can actually study this and really try to like capture what the decibel level is at different times and see if this intervention has really made changes. We're also trying to improve sleep. So we have this sleep menu. The Fenard is the name of one of our buildings. So one of our ICUs we call the FICU, the Fenard ICU. And in that ICU, we will give patients, if they're able to participate in alert, or otherwise families, this sort of sleep menu and say like, hey, how do you sleep at home? You know, do you like the lights on? Do you like the lights off? Do you wear earplugs? Do you wear an eye mask? And if you can, meaning if they're clinically able, because of course some patients, like we can't do this for, but if they can, we will try to honor that. Do you take a sleeping aid at home? Let's make sure that we're giving it to you here. Do you want music on, et cetera? So we give this to people, to the patients and the families immediately on admission and really try hard to honor this. And this is posted on the doors to try to improve sleep at night. One of our other interventions, and this is the newest intervention from the Center for Humanizing the ICU, we just started in September, it's the home intervention. So it's humanizing offerings for the medical environment. So this is a structured initiative to make the ICU room less clinical for those with persistent critical illness. Persistent critical illness is defined in the literature as 10 days in the ICU, so that's our cutoff. And we did this in a structured way because we noticed that we have been doing this, right? So if a patient or a family says, hey, you know, I'd love to like have my dog like come visit, the dog from home. We allow pets to come in when asked. Or, hey, I'd love to like get a meal from Uber Eats. We would let it happen. But then we felt like, you know, this was unjust and not equitable because we were just doing this for people that asked us. What about all these families and patients that didn't know they could even ask that this was an option? And we were worried, were we doing it for people that we liked or the nice families, or were we doing it for the angry families and trying to appease them? So we thought, like, how can we do this across the board? How can we make sure that we are equitably offering these things? So now we sort of have people screen in at 10 days. So our resource nurses, when they meet weekly, will look at the list and say, okay, who's like hit this mark of 10 days? And then what are they eligible for? So there's a list that you see here: pet therapy, music therapy, room and window decorations, time outside, special visitor considerations, a special meal, or additional things. We don't give this to the patient or the family because many of these things, like going outside, everyone wants to do that. Not everyone is able to do that. So we don't give it to them, but we have the resource nurses and the team sort of talk and say, like, what might this patient benefit from? And the nurses will often talk to the families and get a sense of what a patient may or may not like. And so we just started this, as I mentioned, in September. One of our residents just submitted an abstract to ATS for this. But you can see since September, we've had 27 patients enrolled. Our average age was 64, 52% women, 70% white, 22% black. And these are the main interventions. So there's obviously more. This doesn't add up to 48, but these are the main things. So cozy blankets. This, I cannot underestimate the power of a non-clinical blanket. So we have a lot of just fleece blankets from Amazon. We have people donate blankets, and patients and families love it. Just to have, like, not a white hospital blanket is really meaningful. We decorate patients' rooms, so we have window clings that we'll put up, snowflakes now. We'll have hearts for Valentine's Day. We have leaves in the fall. We have pet therapy visits, so our pet therapy program at BIDMC, but also pets from home. If people ask us about pets, we usually always say yes. One time I said no. It was a very large, angry dog that the family described it as a large, angry dog. And I'm like, you're not helping your cause here. But we will always say yes and allow this to happen. The other thing that we do a lot now is take people outside. So this is a picture, and this was a recent photo sent to me, so I wasn't able to get everyone's permission, which is why I blacked out their faces, of our respiratory therapist, our nurse, and a patient outside our Rosenberg building in Jocelyn Park, we call it. We also have a really nice healing garden, which is on a roof, that we take patients to as well. And this is a really powerful and important intervention, and something that we're trying to do more and more of. This is challenging, and we're in the process of actually writing this up as a guideline, really focusing on patient eligibility, team transfer personnel, who's needed, how many people do you need, what do you do in an emergency? Because people want to do this, but they want to feel like it's safe to do this. So we're working a lot on, the guidelines for this and how we can really help people safely transfer outside. We've done this as part of our home initiative a handful of times so far, and I wanted to share some of the quotes. My favorite is, "It was amazing to feel the sun." And then this quote here on the bottom from the patient's grandmother, "This is such a great day. This is a new start for my granddaughter." But being able to go outside, especially for these patients who have been in the ICU for a long time, is a small thing that we can do for them. It takes a lot of work. And when we have staffing challenges, which I know we all do, we have beds closed because we don't have enough nurses. I totally get it. It can be hard to do this when you need a respiratory therapist and a nurse, sometimes a physical therapist. But if you can make it work, I think it's really powerful and really important. And the way that we operationalize this is in the morning on huddle, before we start rounds, we kind of quickly go through all the patients, and the nurses will present the patients. And we talk about, can anyone go outside today? We'll be stopping that shortly because our weather is the same as yours right now. But we say, can anyone go outside? And if we identify someone, we say, do we have the staff to do it today? And if we don't, we don't, and that's okay. And then we say, okay, let's try for tomorrow. Or, we don't really have the staff, but maybe we could send a nurse over from A and try to do it at this time or that time. And be thoughtful and be intentional about it. And it works if you do that. And it's not always going to work. But once you start doing this, people really see the benefit, and the staff really love it too, and are asking more and more, can we take this person outside? Which I think is really important. We also did a big project where we sort of overhauled our waiting rooms. So we moved ICUs last year just from the 7th floor down to the 6th floor, and we're able to reconfigure the waiting room a little bit. And one thing I really wanted changed, which I don't have a great picture of here, is our waiting room was just like lines of chairs that I felt like was really awkward. You're just kind of staring at each other. So now we have little groups of seating, almost like a hotel lobby, where families can just sort of congregate and have some little privacy. We also started a magazine drive. So we have these, you can see here, these white things here in each of the units. So once you're done reading your magazine, you can bring it in. We'll recycle it for the waiting room. We did a survey, put a QR code up, how can we improve this waiting room, help us fix this? And that was the number one thing. People were like, can we please have updated magazines and not like these magazines from the 1990s? So I'm proud to say that we actually have magazines that are relevant. There are fall and winter magazines now in our waiting rooms. We have cell phone chargers. We have puzzles. We have different games. We have posters now with these visitor resources. So there are QR codes for mindfulness apps, so things that you can do while you're waiting so that you can feel sort of less anxious. We have these family meeting carts that we can roll into family meeting rooms with which you can see some hard candy on it, bottles of water on the bottom, tissues, the nice actual Kleenex, not hospital-grade tissues, and little notebooks and pens. So all of these live in our waiting room now. We also have a coloring poster, and this is something that I'm most proud of. So this is just hung up on the wall, and we have a little bucket of colored pencils underneath. We're on our fourth. We just actually took our third one down and hung our fourth one up on Monday. And when we hang it up, we just color one little dot just to signal to people, like, hey, you can color this. This is for you. And what happened, this is our first poster. What organically happened, and you can see here, is people started writing notes to each other. I'll just highlight it so you can see here. So, rest in happiness, Madison, love you. And it was so meaningful and so powerful. We didn't tell them to do that. They just started organically doing it. And the posters are filled out with these notes of support. And it was like a nice way for the families in the waiting room to build community with each other and build community for all the patients. And it's so lovely to see this. And again, it was wonderful because it just organically happened. We didn't tell anyone to do that. We just, colored in a little circle and let them have at it. And I think it's such a nice way. So we're framing all these now and hanging them up in the hallway outside of our ICU. But this, again, was a really small, really cheap, this is from Amazon. It was like $10, a couple colored pencils, really cheap intervention, but has gone a long way to humanize the space and humanize the experience. We owe a lot of this to our Patient and Family Advisories Committee, so we are lucky to have a very engaged ICU PFAC. We have 8 advisors. I have a little bit of the history of PFACs at BIDMC. So the first one was started in 2006 in the neonatal ICU. They're actually called the NFAC, the Neonatal Family Advisory Committee. Massachusetts actually has a law that was passed in 2008 that all acute care and rehab hospitals must have a hospital-wide Patient and Family Advisories Committee. So in 2008, actually, our ICU PFAC at BIDMC was started. In 2010, the hospital-wide one was started. In 2017, the ICU one was disbanded just because they didn't have enough sort of staff engagement to run it, but then also many of the advisors sit on both the hospital-wide and the ICU one, so they just kind of folded them into the hospital-wide. And then in 2022, we restarted the ICU PFAC, which I'm really excited about and really proud about. And currently, there's 3 PFACs at BIDMC with 40 active advisors. And a little bit about our ICU PFAC. So we're lucky to have a dedicated social worker, not just for ICU. She's in charge of patient and family engagement, but she runs our ICU PFAC with me. We have 8 members, as I mentioned, and 5 staff advisors. And we meet quarterly with them, virtually, 2-hour meetings, and we have some ad hoc meetings, PRN, and go back and forth via emails. So they help us with all of these projects and all of these humanizing projects and give us great ideas of what we should put in the waiting room, how we should ask people, how we should phrase the surveys, et cetera, how to make sure that we're getting magazines that are not just for white people, like all these things that, maybe we don't think about. Making sure that one of the complaints from one of our PFAC advisors was all the magazines are for women. Like there's no magazines that men want to read in waiting rooms. I'm like, wow, I never thought of that, but that's so true. So helping us think about these things. And I'm just sharing some of the quotes. One of our staff advisors said that it helps, it reconnects providers to the work. And I think this is an important way, again, to take care of our providers. And one of our patients said, you are advocating for all those that don't have a voice. And one of our family members said, I know all the small things will lead to great impacts. And so it's really powerful and important for them and powerful and important for us. And one of the favorite parts of my job, and doesn't take too much time. Again, we are lucky to have a dedicated social worker. So I wanted to talk a little bit and finish up with the last 2 pieces of this. They're monitoring for PICS and this sort of taking care of the provider. So PICS is post-intensive care syndrome and post-intensive care syndrome for the family. And it's when there's new or worsening symptoms in one of the following domains: cognitive function, psychiatric function, and physical function. The way that we handle this is we educate staff about this. So we've done a lot of talks for our house staff about this. We've done a lot of talks for nursing to really just have people be aware, to be able to talk about it, to be able to talk to patients and families about it. And we have awareness for patients and families. So we have posters about this in our waiting rooms. As I mentioned in our diaries, we have some 2 pages on PICS, what this is. This should be expected. You may feel this way. We sort of teach them that this is an expectation that you're going to feel this way and here's how we can help you. Then we have our survivorship clinic, and we try to refer as many patients as we can to this survivorship clinic, or referral to the appropriate consultants as needed, physical therapy, neuro, et cetera. This is Kate Berg. She runs our survivorship clinic. And the way that we do it is we in the ICU will send an email to her and her team to say, hey, this person would benefit, and then they sort of reach out. What we were doing was putting this on everyone's discharge paperwork from the ICU and telling the patients and the families to call, but that was just too passive. She wasn't getting enough referrals. People were like, what is this survivorship clinic? Do I need it? So we're trying to give her and her team referrals so they can talk to the patients and families while they're still in-house and sort of set this up so the patients and the families know. Many of these she does via telehealth just because it's easier. The patients and families can't travel as easily, and she's been very successful in telehealth. And this has been so important, actually, not just for the patients and the families, but also for the providers. So this was an email that I literally got yesterday, and I updated my slides and sent them. So thank you very much, Shania, for changing my talk, because I wanted to get this in there, because I think it's important, and it's a way that we take care of each other. So Kate said, hi, Molly, Michelle, and Dante. I saw patient X today in my ICU follow-up clinic by telehealth. She was in and out of the MICU with hypotension and hypoxemia and a lot of delirium. She has been home since September, still recovering, but is just graduating from home PT to outpatient PT, able to walk around a little and very laboriously get up and down the stairs, cognitively back to herself, also back to cooking in her kitchen at home, for which she is very grateful. She does not remember a lot about her ICU, but she does remember you, Dante. Dante's one of our nurses, and how wonderful you were to her. Just wanted to let you know that you are appreciated and that she is doing well. Kate sends these emails all the time, and it's amazing. She sends it to anyone who's named in one of these clinic visits. She'll send them an email, and she'll usually CC me as the medical director, and then Michelle is our nursing director. And this goes such a long way to really make people feel good about the work that we're doing. And Dante immediately wrote back, oh my gosh, I remember her, so thank you so much. This makes my day. I was having such a bad day today. So these really small things really go a long way to help people feel good about the work that they're doing. And the last piece of this is caring for providers, which deserves a whole talk in and of itself. Burnout is common in the ICU, and we all know that. And there's many reasons, and you can see in this complex figure here, many reasons for it, many things that contribute to it, many things that are related to it. And I don't have all the answers for how to fix this. We've done a few things to try to change the system. We now have 2 overnight attendings, which is more overnights for everyone, but less physical work when you're there. You're able to maybe get a little sleep and function in clinic the next day. So trying to change the system, trying to make the work easier and more palatable. We do something called resiliency rounds and wellness rounds. But really, truly, what I feel is if you are able to humanize the infrastructure, that's a way that we can take care of providers. So much of this humanizing work, I really think is going to benefit the providers. And our hope is that people can feel more connected to the work that they're doing and feel better about their jobs. So these are my take-home points. I'll just leave here. But dehumanization is common in critical care. And hopefully with these steps, you can see that there are ways to humanize the experience. This is Somnath Bose and Elaine Klatt from the Center for Humanizing the ICU. Somnath is an anesthesiologist and intensivist at BIDMC, who's my co-director, and Elaine is our director of operations. And just wanted to thank everyone who's benefited me and really helped me, who I have benefited from, I should say, and who has helped me along the way, and most especially all of the patients and the families who really helped us do this work. So thank you so much. I'm happy to take any questions.
Thank you very much for a very inspiring talk. And do you have any questions in the audience, Steve?
Fantastic. And I applaud you for the work you've done, your innovations, your ideas, and it really goes to show you can do a lot without having to invest a lot in terms of resources.
Yeah.
We run a program here called Learning to Talk, which sort of helps to manage communication. And one of the things that we address is how do we handle autopsy? Mm-hmm. So I'm curious if there's anything there. And then one of the things that I've personally done, although as I was listening to you, I thought, I've never really thought about the institution is an expression of condolence through writing a card. Especially, I'm a nephrologist for patients that I have a long-term relationship. I don't know if there's any thought that you've given to doing something like that.
Yeah.
I welcome your feedback.
Yeah, so for autopsy, it's actually interesting you mentioned that. We're just in the process of changing our sort of paperwork and how we teach people to talk about autopsy, mostly because our pathology department cannot keep up with the amount of autopsies. So the way that our paperwork is written is that everyone needs, is that what's going on here too?
Exact opposite.
Oh, interesting. You're trying to get more. So everyone has been coached to offer an autopsy to every single family. And actually some of our residents thought, I thought this was a Massachusetts law because the paperwork says talk to the family. It's not a law. So we're trying to now teach them to only offer it when we think that we really want it. But the way that we had been coaching them, which maybe this will help you and I can send you our old forms, was that we say this is a service that the hospital provides, and it's sort of just like a very common routine thing, and they're coached to mention it and say, I have to talk to you about this, I have to ask you about this. But it led to a lot of people saying, yeah, I do want an autopsy, and now pathology can't keep up with it, so we're shifting gears a little bit. And then the condolence cards, we actually do send sympathy cards. This is part of our Center for Humanizing the ICU. There was one small study, though, in the literature that said this actually caused harm to the family, so it gave me a little bit of pause. But there's a small study. There's other studies saying that this is powerful and important. And I get thank you emails from families when we send these cards. So we have them printed up. We have some with a little saying in it and others that are just blank, and everyone will sign it. And then our operation right now is that they leave it in my mailbox and I address them and send them, which needs to change because it's becoming a little onerous. But that has been the challenge when we tried this before. How do you operationalize it? Like, who's going to send them? Who's going to do this? So we had an attending in the past who just kind of took this on, and it became too challenging for her. So we folded it into the Center for Humanizing the ICU, but need to figure out a better operational plan, which I'm hopeful that we can use the unit coordinators to do. But I think it's really valuable, and we've only had positive feedback about it.
Thank you.
Dr. Chowdhury.
So one of the most humanizing things that I see is keeping people NPO on the night before, and they're going to be getting the procedure late in the day. How do you address that? Because this is one of the most, people don't forget that they were left hungry and thirsty.
Yeah. Yeah. It's a challenge for sure. We try hard to work with the procedural teams to say, is this really going to happen? Is this not going to happen? Which I know is always, they're an add-on. We're going to try to get to them. And then we just really try to set the expectation that this may happen. We have welcome to the ICU guides and posters in the ICU, and a book and a PDF and a QR code. And we have that in there that unfortunately you might not be able to eat for X amount of time. So we've just been trying to set the expectation. But it's a huge problem. We actually had a patient recently. He had toy scissors in his bag. He tried to slit his wrist with his toy scissors because he was so hungry. That's what he told us. And that was such a powerful moment. I think we all know that. It's awful to leave people hungry. But when this actually happened, we were wow, we need to figure this out. We need to change something. We're also been working with many of the proceduralists. You don't need 24 or 12 hours. So can you tell us what time? Tell us realistically what time do you think you're going to get there, and let's do this 6 hours or 8 hours. Let's work with anesthesia and the proceduralist. So we've been trying to do that, but we've just been setting the expectation that this is going to happen. But it's a huge problem. Yeah. Yep. Yeah.
So we are running a little bit over time here, and there's another conference that it's going to start. So I suggest to send us, Shania, can we send an email, contact us further questions? And we are going to end this session. So thank you very much for
Thank you.
all the inspiring ideas.
Thank you.
So now we're going to have to go with the fellows conference. Thank you very much. Man, the infrastructure. With all of these pieces. Yeah. You have to add something. You get in and did you just use whatever you had as an infrastructure?
In the waiting room?
Waiting room, resource nurse, cards.
Yeah.
Hey,
Hi.
Molly, go.